tell us that we need to implement optimal medical therapy in all patients. So in this case, that means secondary prevention of coronary artery disease events, diabetes control, management of myocardial ischemia and the angina symptoms of this patient. And for this, the ESC recommends that we treat the risk factors aggressively. Indication is 1A, that we carry out studies to assess the heart rhythm in these patients, that we give it an ACE inhibitor, that we use one of the new anti-diabetic drugs which have prognostic importance, and that we ensure as much as we can that we know the coronary anatomy of these patients in case they need revascularization. So what we did with this patient was to ensure that he followed the proper diet, that he exercised regularly, that he did not smoke. We ensured that he took his tablets regularly and recommended annual influenza vaccination. We gave him aspirin and clopidogrel, which is a 2A recommendation of the ESC guidelines, added a proton pump inhibitor, gave him ramipril 10 milligrams once daily, atorvastatin to keep his cholesterol levels low, and we achieved a very good level of 1.5 millimoles per liter. He was kept on metformin, which he used to take either 500 milligrams twice daily or 800 milligrams once daily or up to 1,000 once daily. And we added empagliflozin. The problem was that although all of these treatments were in place and they would actually in a way be useful for disease prevention, the patient continued to have myocardial ischemia and angina. We attempted low dose bisoprolol, which had to be discontinued because of low blood pressure. Diltiazem and long-acting nitrates caused headaches and hypotension, so we couldn't use it. So we decided to add ranolazine with an initial dose of 375 milligrams twice daily, which was up titrated to 750 milligrams over 3 months. And that reduced the effort angina dramatically to just occasional monthly episodes of chest pain. And I reckon that the effect was essentially on both the ischemia triggered by the stenosis of the circumflex, but also by reducing the microvascular angina. And the guidelines of the ESC endorse our decision to use ranolazine because they tell us that when there are problems with the use of first-line drugs, we can use some of the secondary agents, second-line agents like ranolazine, which in this case, in my view, represents a first-line treatment because it tackles two important mechanisms for ischemia in this patient. We decided to use ranolazine because this patient had a low heart rate at baseline and also low blood pressure. And this is a very good indication for ranolazine.